During the primary survey of a pediatric trauma patient, a nurse observed significant intercostal retractions and nasal flaring in a 4-year-old. What does this finding indicate, and what immediate interventions should be considered? Answer: significant intercostal retractions and nasal flaring in a pediatric patient indicate respiratory distress. These signs suggest that the child is struggling to maintain adequate ventilation, which can rapidly progress to respiratory failure if not promptly addressed. In pediatric patients, airway compromise is a major concern, and these physical findings are important markers of increasing respiratory effort. The immediate interventions for this child should include airway assessment. The nurse should immediately check for any obstructions or foreign bodies in the airway, ensuring it is clear to facilitate normal breathing. Oxygen administration. Supplemental oxygen should be provided to improve oxygenation. This can be done via a nasal cannula or a face mask, depending on the child's tolerance and the severity of distress. Oxygen saturation should be closely monitored and maintained above 94% if possible. Consider non-invasive ventilation. If the child's respiratory distress persists despite oxygen therapy, non-invasive ventilation options, such as CPAP, continuous positive airway pressure, or BiPAP, bi-level positive airway pressure, should be considered to help improve alveolar ventilation and prevent further deterioration. Positioning. Position the child in a comfortable, sitting or semi-upright position to maximize chest expansion and ease breathing. Early intervention is key to preventing respiratory failure, which can lead to hypoxia and, in extreme cases, cardiorespiratory arrest. According to PALS Pediatric Advanced Life Support Guidelines, effective airway management, oxygen therapy, and continuous monitoring are vital in managing pediatric respiratory distress. What are the critical components of an asthma exacerbation protocol in a pediatric emergency setting, and how would the nurse assess for signs of impending respiratory failure? Answer: asthma exacerbations in pediatric patients are commonly triggered by viral infections, allergens, or environmental factors. The critical components of an asthma exacerbation protocol include bronchodilator therapy. The initial treatment involves administering short-acting beta agonists, such as albuterol via nebulizer or metered-dose inhaler with a spacer. This helps to relax bronchial smooth muscle, opening the airways and improving airflow. Corticosteroids. Systemic corticosteroids, oral or intravenous, should be given to reduce inflammation and prevent worsening of symptoms. These medications typically take 4-6 hours to show their full effects, so early initiation is key. Oxygen therapy. If the patient's oxygen saturation falls below 94%, supplemental oxygen should be administered to maintain adequate oxygen levels and prevent hypoxia. Continuous monitoring. Frequent reassessment of respiratory rate, work of breathing, pulse oximetry, and auscultation of lung sounds is essential. Consider additional medications. If the initial treatments do not provide adequate relief, further options such as magnesium sulfate or epinephrine may be indicated as per clinical guidelines. Signs of impending respiratory failure include silent chest, decreased or absent breath sounds on auscultation due to severe airflow obstruction, tachypnea, and use of accessory muscles. This indicates the child is working harder to breathe. Hypoxia. Persistent oxygen saturation levels below 90% despite therapy. Altered mental status. An indication that the brain is not getting enough oxygen. The Global Initiative for Asthma, GINA, guidelines stress the importance of early intervention with bronchodilators, steroids, and oxygen, as delay in treatment can lead to severe respiratory distress or failure. What non-pharmacologic techniques can be effective for managing pain in a nonverbal toddler undergoing a minor painful procedure, and why are these strategies important in pediatric care? Answer: non-pharmacologic pain management techniques are essential, particularly in nonverbal toddlers who cannot communicate their pain. These techniques aim to reduce distress, promote comfort, and enhance the child's coping abilities during procedures. Effective non-pharmacologic methods include distraction. Using toys, bubbles, or even electronic devices like videos can capture the child's attention and redirect focus from the procedure, reducing perceived pain. Parental involvement. Allowing the parent to hold or comfort the child during the procedure provides emotional security. The child often feels safer and less anxious in the presence of a familiar caregiver. Comforting touch. Gentle caressing, rocking, or holding can have a calming effect on the child, providing both emotional and physical comfort. Use of soothing music. Familiar songs or sounds can provide auditory distraction, which can help the child focus on something pleasant, reducing their perception of pain. Positive reinforcement. Praising and rewarding the child post-procedure can help them associate medical experiences with positive outcomes. thus reducing anxiety for future visits. Marcus, a 3-year-old, presents with sudden onset of choking while eating. He is coughing vigorously but is able to breathe and cry. What steps should the nurse take considering pediatric airway obstruction protocols? Answer: in this scenario, Marcus is experiencing a partial airway obstruction according to PALS and American Heart Association guidelines. The key is to support Marcus while allowing him to clear the obstruction on his own if possible. Since he is coughing and able to cry, the following steps should be taken. Encourage coughing. As long as Marcus is coughing and able to breathe, the best approach is to allow him to continue coughing to try to expel the object. The act of coughing is often effective in dislodging a small foreign body. Monitor closely. The nurse should continue to observe Marcus closely for any signs of worsening airway obstruction. If his ability to cough or breathe decreases, intervention is required. Prepare for emergency action. If the coughing becomes ineffective or Marcus shows signs of complete obstruction, e.g. inability to breathe, blue lips, or inability to speak, the nurse should be ready to perform back blows and chest thrusts. For children under 4 years old, back blows should be administered by delivering 5 firm blows between the shoulder blades, followed by 5 chest thrusts. What are the distinct characteristics and treatments for hypovolemic and distributive shock in pediatric patients? Answer: hypovolemic shock and distributive shock are 2 different types of shock that require distinct treatment approaches in pediatric patients. Hypovolemic shock cause. This occurs due to a significant loss of fluid or blood, commonly due to dehydration, hemorrhage, or severe vomiting, diarrhea. Signs: tachycardia, hypotension, pale or cool extremities, delayed capillary refill, and reduced urine output. Treatment: the primary treatment is fluid resuscitation using isotonic fluids like normal saline or lactated ringers. The child should receive 20 mg boluses of fluid and reassessed after each bolus to gauge response. If the child's condition doesn't improve, blood products may be needed in the case of significant blood loss. Distributive shock cause. This is often caused by conditions like septic shock or anaphylaxis, where the vascular tone is lost, leading to abnormal distribution of blood. Signs: warm, flushed skin, bounding pulses, hypotension, and often fever. Septic treatment: in addition to fluid resuscitation, vasoactive medications like dopamine or norepinephrine may be required to increase vascular tone and restore circulation. If the shock is septic, antibiotics should be started immediately after obtaining cultures in line with PALS and surviving sepsis campaign guidelines. Both types of shock require careful monitoring and reassessment with fluid therapy and pharmacological interventions tailored to the patient's response. Explain the significance of the pediatric Glasgow Coma PDCS and how it assists in assessing neurological function in an unresponsive infant. Answer: the pediatric Glasgow Coma PDCS, a tool used to assess the neurological status of pediatric patients, helping healthcare providers determine the severity of head injury or neurological impairment. It is particularly useful in unresponsive infants and children as it provides a more accurate measure of their level of consciousness compared to the adult version of the Glasgow Coma Scale. The PGCS is divided into 3 components. Eye-opening response ranges from spontaneous eye-opening, score 4, to no eye-opening, score 1. Verbal response. For infants, this ranges from crying appropriately, score 5, to no verbal response, score 1. Motor response involves assessing the child's ability to respond to stimuli from purposeful movement. Score 6, to no movement, score 1. The scores from these 3 components are added together with the total possible score ranging from 3 deep coma to 15 normal. What is the role of early antibiotics in the management of pediatric sepsis, and how do you prioritize their administration? Answer: early administration of broad-spectrum antibiotics is essential in managing pediatric sepsis as it can significantly reduce morbidity and mortality. The primary goal is to initiate antibiotic therapy within 1 hour of recognition of sepsis to target the potential pathogens that could be causing the infection. The key steps include prompt identification. The nurse must quickly recognize signs of sepsis, including fever, tachycardia, hypotension, and altered mental status. Blood cultures. Blood cultures should be obtained before administering antibiotics whenever possible, but if delayed, treatment should not be postponed. Broad-spectrum antibiotics. Initial therapy typically includes beta-lactam antibiotics, such as ceftriaxone or piperacillin-tazobactam, combined with vancomycin or clindamycin to cover both gram-positive and gram-negative organisms, including MRSA. Just antibiotics. After culture results are available, The antibiotic regimen should be adjusted to target the specific pathogens. Sepsis management also involves fluid resuscitation, vasopressors for refractory shock, and monitoring organ function, especially kidney and cardiovascular function. What are the priorities in the immediate management of a pediatric patient with a suspected femur fracture after a fall from height? Answer: the immediate management of a pediatric femur fracture after fall focuses on preventing further injury, managing pain, and stabilizing the patient. Key priorities include assessment of a BCS airway, breathing, circulation, ensure the airway is clear, the child is breathing adequately, and there is no life-threatening bleeding. Pain management, administer analgesics to relieve pain either via systemic medications, e.g. acetaminophen or ibuprofen, or regional nerve blocks if appropriate. Immobilization. The affected leg should be immobilized using a splint or traction to prevent movement, reduce pain, and prevent further vascular or nerve injury. Monitoring for shock. Check for signs of shock, including tachycardia, hypotension, and pallor, which could indicate significant blood loss from the fracture. Transport to a trauma center. The child should be transported to an appropriate medical facility for further evaluation, imaging, and surgical management if necessary. Femur fractures in children often require surgical intervention, such as the insertion of intramedullary rods or plates to stabilize the fracture. How should a pediatric patient with moderate dehydration from gastroenteritis be managed? Answer: moderate dehydration in a pediatric patient, typically defined by signs like reduced skin turgor, dry mucous membranes, and increased thirst, can be managed with oral rehydration therapy or intravenous fluids if ORT is not effective. Management strategies include oral rehydration. Administer an oral rehydration solution or containing electrolytes and glucose. The child should receive small, frequent sips to prevent vomiting and promote absorption. The goal is to replace lost fluids gradually. Intravenous fluids. If the child cannot tolerate oral fluids or shows signs of worsening dehydration, IV fluids, such as lactated ringers or normal saline, may be indicated. The initial bolus is usually 20 AG, assessing the child's response before giving more. Monitor. Frequent reassessment of vital signs, urine output, and clinical signs of hydration status should be conducted to ensure proper fluid balance. What should be the initial approach to managing a pediatric patient who is having a generalized tonic-clonic seizure? Answer: in a pediatric patient experiencing a generalized tonic-clonic seizure, the initial approach should focus on safety. Ensure the environment is safe to prevent injury. Move any nearby objects that could harm the child. Airway protection. Place the child on their side to help clear any potential airway obstructions and prevent aspiration. Time the seizure. Seizures should be timed for duration, as interventions are typically required for seizures lasting longer than 5 minutes. Status epilepticus. Antiepileptic drugs. If the seizure lasts more than 5 minutes, benzodiazepines, e.g. lorazepam or diazepam, should be administered to abort the seizure. Post-ictal care. After the seizure, the child should be monitored closely as they regain consciousness. Ensure they are kept in a safe position and observe for any signs of complications. Seizure management protocols should follow guidelines from the American Epilepsy Society to minimize the risk of brain injury and other complications. 3-year-old patient is brought into the emergency department after having a generalized tonic-clonic seizure lasting for 6 minutes. The child's fever is 39.5 Dic, and there are no signs of injury or trauma. What would be the most appropriate next step in management, and how do you differentiate this case from a potential febrile seizure? Answer: in this scenario, the most likely diagnosis is a febrile seizure, given the child's age and the presence of fever. According to the American Academy of Pediatrics, febrile seizures are typically seen in children between 6 months and 5 years of age and are often associated with a rapid increase in body temperature. Management includes the following steps. Supportive care. Ensure the airway is clear, provide oxygen if needed, and monitor vital signs. Antipyretics. Administer acetaminophen or ibuprofen to manage fever, though these do not stop the seizure. Seizure management. If the seizure lasts longer than 5 minutes, initiate medication to abort the seizure. First-line agents include benzodiazepines, e.g. lorazepam, which can be given intravenously or rectally if intravenous access is not available. Differentiating from an febrile seizure involves evaluating for underlying causes such as a history of epilepsy, neurological abnormalities, or prior seizures without fever. If a febrile seizure is suspected, avoid over-investigation unless there are concerns for underlying pathology such as meningitis or a CNS infection, especially if the child is very young or has an abnormal neurologic exam. What are the key clinical signs of increased intracranial pressure in a pediatric patient, and how would you manage a suspected herniation? Answer. Signs of increased ICP in pediatric patients include papilledema, swelling of the optic disc due to raised intracranial pressure visible on fundoscopy, Cushing's triad, a late sign consisting of hypertension, bradycardia, and irregular respirations. It is a classic indicator of impending brainstem herniation, headache, vomiting, and altered mental status. Particularly in infants, vomiting can be associated with ICP elevation. Management of suspected herniation involves immediate and aggressive measures. Osmotic agents administer mannitol or hypertonic saline to reduce ICP by drawing fluid out of the brain tissue. Neuroprotective measures elevate the head of the bed to third siding, maintain proper ventilation, and avoid hypoxia or hypocarbia. Surgical intervention. If there is a risk of herniation, urgent consultation with a pediatric neurosurgeon is needed to assess the need for surgical decompression. A 4-year-old child is brought to the emergency department after a fall from a playground slide landing on their head. The child appears lethargic but is rousable with verbal stimuli. The family reports no loss of consciousness but mentions that the child is holding their head and crying. What steps should be taken to evaluate and manage this child? Answer. In this scenario, the child may have sustained a mild head injury or concussion. The steps to evaluate and manage this child include primary survey, ensure airway, breathing, and circulation are intact, neurological assessment, perform a pediatric Glasgow Coma Scale (GCS) assessment. In this case, the child is rousable with verbal stimuli, which would correspond to a GCS score of 1-3-1-5. Rule out severe injury, given the lack of loss of consciousness, but with lethargy and head pain, a head CT scan may be considered based on clinical judgment, especially if the child shows signs of deteriorating mental status or if there is suspicion of intracranial hemorrhage. Concussion protocol. If the diagnosis is concussion, the child should be monitored for worsening symptoms, e.g., vomiting, confusion, and advised to rest with a gradual return to normal activities under medical guidance. It's also crucial to assess for signs of basilar skull fracture, e.g., Rakuna's battle signs, or cerebral contusion. A 7-year-old boy presents to the emergency department after falling off his bike and landing on his outstretched hand. X-ray reveals a Salter-Harris type I fracture of the distal radius. What is the significance of a Salter-Harris fracture in pediatric trauma, and what is the appropriate management? Answer. Salter-Harris fractures involve the growth plate and can have significant long-term implications for bone development. Type I fractures are the most common and involve the metaphysis and growth plate. Management. Reduction and immobilization. Non-displaced fractures can be managed with closed reduction and casting. If displaced, an open reduction may be necessary. Follow-up imaging. Regular follow-up X-rays are important to assess for any signs of growth disturbance or improper healing. Long-term considerations. Depending on the degree of displacement and the involvement of the growth plate, there is a risk of future growth disturbances, which could result in angular deformities or shortened limbs. In Salter-Harris type I fractures, the prognosis is generally good if treated early and appropriately, but careful monitoring is needed to ensure proper healing. A 2-year-old girl is involved in a motor vehicle collision, and emergency responders report that she is alert but experiencing neck pain and reluctance to move her head. What specific immobilization technique is appropriate for pediatric patients, and why is it critical to adjust methods based on the child's age? Answer. Spinal immobilization in pediatric patients must be tailored to the child's anatomical and developmental characteristics. For this 2-year-old girl, neck stabilization. The use of a pediatric cervical collar is appropriate, but it is essential to remember that standard adult collars may not provide adequate stabilization for young children. Pediatric-sized collars are specifically designed to account for smaller neck and airway dimensions. Spinal precautions. The child should be placed on a pediatric backboard and all movements should be minimized. In younger children, the cervical spine is more flexible and inadvertent movement could worsen injury. Airway considerations. Pediatric patients have smaller airways and are more prone to airway obstruction during immobilization. Techniques such as gentle chin lift or jaw thrust should be used to maintain patency of the airway without compromising spinal stability. Spinal immobilization in children is crucial because their bones are softer and their necks and spines may be more prone to injury, especially in high-impact trauma situations. What are the critical components of a primary and secondary trauma survey for a pediatric patient presenting after fall from a height? Answer. Primary trauma survey focuses on identifying and addressing life-threatening injuries. Airway. Assess for patency, especially with head or facial trauma. breathing, ensure adequate ventilation and oxygenation circulation, check for signs of shock, tachycardia, hypotension, and control any external bleeding. Disability, perform a quick neurological exam including GCS to assess the level of consciousness. Exposure, ensure the child is fully exposed to assess for hidden injuries while maintaining warmth. Secondary trauma survey includes a thorough head-to-toe examination, detailed history, mechanism of injury, comprehensive physical exam, focusing on any potential internal injuries, fractures, or contusions. Imaging is needed. CT scan for head trauma or X-rays for fractures. How can you differentiate between febrile seizures and the first febrile seizure in a 2-year-old child with no prior history of seizures? Answer: febrile seizures and afebrile seizures have distinct clinical features. Febrile seizures typically occur in children between 6 months and 5 years, triggered by fever, often a rapid rise. They are usually generalized and last less than 5 minutes. The child may appear well after the seizure. Afebrile seizures occur without a fever and may present as focal seizures or generalized seizures. The child's medical history and family history of epilepsy may raise suspicion for underlying neurological conditions. In both cases, a thorough neurological evaluation and EEG, if necessary, help distinguish between febrile and afebrile seizures. A 4-year-old child presents to the emergency department in shock after vomiting and diarrhea for 48 hours. They appear lethargic and have a heart rate of 150 bpm, with a capillary refill time of 3 seconds. What is the initial fluid resuscitation strategy for this child? Answer: this child likely presents with hypovolemic shock secondary to dehydration from vomiting and diarrhea. Initial management includes initial fluid resuscitation. Administer 20 mg of isotonic solution, normal saline or Ringer's lactate, as a bolus over 2-3 minutes. Reassessment. After the first bolus, reassess the child's clinical status, e.g. vital signs, capillary refill, mental status. If improvement is noted, proceed with further boluses as needed. Maintenance fluids. Once the child is stabilized, calculate the maintenance fluid requirements and continue rehydration via oral rehydration solutions or IV fluids. 5-year-old boy presents with wheezing and difficulty breathing after playing outside. He has a history of asthma but has never required hospitalization. His oxygen saturation is 90% and he is using accessory muscles to breathe. What is the first-line treatment for this child? Answer: in this child with asthma exacerbation and hypoxia, base agonists, e.g. albuterol, are the first-line treatment for bronchodilation. Administer through a nebulizer or metered-dose inhaler with a spacer. Oxygen therapy to maintain oxygen saturation above 94%. Supplemental oxygen is critical for hypochemic patients. Systemic steroids, e.g. prednisolone, are also given to reduce inflammation and prevent recurrence of the exacerbation. Close monitoring is necessary to assess the child's response to treatment and the need for further interventions. A 3-year-old child is brought into the emergency department after ingesting an unknown substance. The child is drooling, has pinpoint pupils, and is bradycardic. What toxidrome do you suspect, and what is the appropriate antidote? Answer: this child exhibits signs of cholinergic poisoning consistent with an organophosphate or carbamate poisoning. Symptoms include salivation, drooling, pinpoint pupils, meiosis, bradycardia, diarrhea, and vomiting. The appropriate antidote is atropine, which blocks the effects of acetylcholine at muscarinic receptors. In severe cases, pralidoxime can be used to reverse the effects of organophosphate poisoning by reactivating acetylcholinesterase. What anatomical differences in a pediatric patient's airway present a higher risk for airway obstruction compared to adults? Discuss how these differences impact emergency care approaches. Answer: pediatric patients have several key anatomical differences that predispose them to airway obstruction, including a proportionately larger tongue, a higher, more anteriorly positioned epiglottis, and smaller and narrower airways. The trachea in infants and young children is also more flexible, making it more susceptible to compression. These differences mean that even minor inflammation or obstruction, e.g. from mucus or foreign bodies, can significantly impact a child's airway patency and respiratory effort. In emergency care, these anatomical distinctions necessitate special airway management techniques. For example, proper positioning. In infants, a neutral or slight sniffing position is critical, whereas excessive head tilt may compress the trachea. Use of appropriate airway adjuncts. Smaller diameter tubes or face masks must be selected based on age, weight, and body size. Prompt suctioning. Due to higher risk of obstruction by mucus, effective suctioning is crucial. Guidelines from the American Heart Association. AHA emphasize prompt and gentle airway clearing and, if necessary, advanced airway support suited for pediatric anatomical features. Describe how the pediatric assessment triangle PAT is used in pediatric triage and explain its three components. Why is the PAT an essential tool in pediatric emergency settings? Answer: the Pediatric Assessment Triangle PAT is a quick, visual triage tool that enables clinicians to assess critically ill or injured children in under a minute without physically touching them. The PAT consists of three components. Appearance: this includes assessing tone, interactiveness, and consolability, which provide cues about neurological status and oxygenation. Work of breathing: visible signs such as nasal flaring, grunting, or use of accessory muscles indicate respiratory distress. Circulation to skin: observing skin color, pallor, mottling, cyanosis offers insight into perfusion and cardiovascular function. The PAT helps rapidly identify life-threatening conditions and prioritize urgent care. Its emphasis on observation aligns with pediatric physiology, where early signs of distress may differ from adults. It is integral in initial pediatric emergency triage, allowing rapid decisions based on clinical appearance before detailed assessment. Explain the rationale for using age-appropriate pain assessment tools in pediatric patients. Name two specific pain assessment tools for young children and describe how they function. Answer: age-appropriate pain assessment tools are essential in pediatric care because children's understanding and expression of pain vary by developmental stage. In young children, subjective self-reporting may not be reliable, so tools that use nonverbal indicators are often more effective. Two commonly used tools include FLACC scale, designed for infants and nonverbal children. This tool evaluates pain based on 5 criteria: face, legs, activity, cry, and consolability, each scored from 0 to 2. It provides a composite pain score that can be quickly assessed through observation. 1 Baker FACE S pain rating scale. This tool uses facial expressions on a 0-1-0 scale to help children aged 3 and up identify their pain level by selecting a face that matches how they feel. These tools are critical for tailoring pain management in pediatrics, ensuring appropriate interventions while respecting children's developmental limitations. Amelia, a 3-year-old, arrives at the with a high fever, lethargy, and inconsolable crying. Her parents mention that she has been refusing fluids and is showing signs of neck stiffness. Using the pediatric assessment triangle, how should the nurse proceed with the initial assessment? What are the possible concerns and what is the next appropriate step? Answer: using the pediatric assessment triangle PAT, the nurse would proceed as follows. Appearance: Amelia's lethargy and inconsolable crying indicate possible neurological impairment or severe illness. Work of breathing: observing for any labor breathing or respiratory effort is essential. Circulation to skin: skin pallor or mottling could suggest poor perfusion, possibly due to dehydration or sepsis. Given her symptoms, fever, lethargy, neck stiffness, meningitis is a significant concern. Immediate stabilization with airway, breathing, and circulation next should follow. According to guidelines, prompt IV fluid resuscitation and antibiotics should be considered after consulting with a physician. This scenario underlines the importance of rapid, structured assessment and early intervention in suspected meningitis cases. What is the AVPU scale and how is it utilized to assess the neurological status of a pediatric patient during the primary survey in emergency care? Answer: the AVPU scale is a simplified method to assess the neurological status and alertness of a patient, particularly useful in emergency settings. It categorizes responses into 4 levels. Alert: the child is fully awake and responsive. V. Verbal: the child responds to verbal stimuli. P. Pain: the child responds only to painful stimuli. Unresponsive: the child shows no response to stimuli. In pediatric emergency care, this scale provides a quick neurological assessment. A deterioration from alert to pain or unresponsive indicates a need for urgent intervention. For a more detailed assessment, the Glasgow Coma Scale (GCS) is used. Discuss the significance of the SAMPLE history in pediatric emergencies. What unique factors should be considered when applying it to pediatric patients? Answer: the SAMPLE history, symptoms, allergies, medications, past medical history, last meal, events leading to illness or injury is pivotal for gathering essential information about a pediatric patient's condition. Unique pediatric considerations include symptoms. Children might not articulate symptoms well, requiring observation of nonverbal cues. Allergies. Parents or caregivers must confirm, as children may not know their allergies. Medications. Ensure accurate details about dosing for weight-based medications. Past medical history, particularly important to check for immunization status and chronic conditions. Last meal. Relevant in surgical emergencies to assess aspiration risk events. Detailed incident reports are critical in trauma cases to rule out abuse or neglect. The SAMPLE framework enables comprehensive history taking while accounting for pediatric-specific risks and developmental limitations. Explain why hypothermia is a greater risk in neonates compared to older children and adults. What measures should be taken to prevent hypothermia in neonates in the emergency department? Answer: neonates are at a higher risk for hypothermia due to their large body surface area relative to mass, limited subcutaneous fat, and underdeveloped thermoregulatory mechanisms. They lose heat more rapidly than older children, particularly through radiation and evaporation. Preventive measures include maintaining a warm environment, use of radiant warmers, and keeping room temperature controlled. Skin-to-skin contact, encouraging skin-to-skin contact when appropriate, use of pre-warmed blankets, covering and insulating the infant promptly after birth or during treatment. Following the American Academy of Pediatrics recommendations, continuous monitoring of temperature and rapid intervention in hypothermic cases are critical in neonates. How does the immature immune system of infants increase their susceptibility to infections, and what precautions should be taken in an emergency setting to prevent infection transmission to these patients? Answer: infants have an immature immune system, with low levels of immunoglobulins and limited production of antibodies, making them more susceptible to infections. Their lack of exposure to pathogens also limits natural immunity development. In an emergency setting, precautions include strict hand hygiene. All staff and caregivers must wash hands frequently. Use of PPE, gloves and masks, especially when treating infectious cases. Isolation protocols. Placing infants with suspected infections in isolated areas to prevent cross-infection. The CDC emphasizes rigorous adherence to infection control protocols to protect vulnerable pediatric populations, including immunocompromised infants. What unique psychological needs do school-aged children have when receiving emergency medical care, and how should nurses address these needs? Answer: school-aged children 6–2 years value autonomy, privacy, and clear communication, especially during medical interventions. Fear of loss of control and modesty concerns are prevalent. Nurses should involve the child in decision-making, offer choices where possible, such as selecting a preferred hand for an IV, explain procedures in age-appropriate terms. This reduces anxiety by promoting understanding, respect privacy, use drapes, and only expose areas required for assessment or treatment. Guidelines from the Pediatric Nursing Certification Board (PCSCB) emphasize developmentally sensitive communication, which fosters trust and cooperation in school-aged children. Describe the pathophysiology of bronchiolitis in infants and the key clinical features that help differentiate it from other respiratory illnesses. What are the main management strategies for a child diagnosed with bronchiolitis? Answer: pathophysiology. Bronchiolitis is a viral infection most commonly caused by the respiratory syncytial virus RSV, which leads to inflammation and obstruction of the small airways, bronchioles, in the lungs. This inflammation causes increased mucus production, airway narrowing, and difficulty in clearing secretions, leading to respiratory distress. Clinical features: initial symptoms, runny nose, cough, and low-grade fever. Progressive symptoms: wheezing, rapid breathing, tachypnea, nasal flaring, and chest retractions. Differentiation from other illnesses: unlike asthma, which is a chronic condition with reversible bronchospasm, bronchiolitis tends to present in infants with viral prodromes progressing to respiratory distress. Bronchiolitis is also more common in children younger than 2 years. Management: oxygen therapy. If oxygen saturation is below 90%, supplemental oxygen should be administered. Supportive care: hydration, nasal suctioning to clear mucus, and maintaining adequate nutrition. Bronchodilators: these may be trialed, but their effectiveness in bronchiolitis is controversial. Hospitalization required for infants who show signs of severe distress, dehydration, or require respiratory support. The American Academy of Pediatrics advises supportive care as the cornerstone, with minimal use of medications unless complications arise.